Okay, welcome back. Today we're going to be talking about describing symptoms and prevalence of two disorders. This is Learning Outcome 5.4 for IB Psychology, Abnormal Levels of Analysis. Again, we want to have a short little review of 5.3 before we go on. In 5.3, we talked about how culture affects the diagnosis, how we have to consider cultural variances in our discussion of diagnosis, and this was a Ballinger study that led us to believe that it suggests that variations in diagnosis across cultures do not necessarily reflect social or medical realities. Again, that culture and diagnosis don't necessarily go hand in hand. What's good for the goose is good for the gander only culturally, okay? Then we talked about ethical considerations in making diagnosis. And with that, we looked at, where was it at? Ethical considerations. Oh, here we go. Ethical considerations, finding the correct diagnosis and the treatment for what we have going on. With it came bias of diagnosis, and that is looking at socioeconomic groups, various cultural groups, gender, ethnicity, religious ethnicity, considerations of normality and abnormality, and stigmatization, which was the Rosenhan study of 1975. We also talked about emic and etic in diagnosis, looking from the inside out and the outside in. What is unique to a particular culture? Does it fit other cultures as well too in a diagnosis, or are we looking for a very specific cultural related kind of a diagnosis? And these go on to help us when we take the next step here, and that is 5.4, when we look at describing symptoms and prevalence of two disorders. And now the book, the study guide, gives you actually three to choose from: anxiety, affective, and then eating disorder. We do not talk about anxiety disorder at all, and you'll notice that the study guide only gives you really two: affective and eating disorders. So let's go on. Here, we need to be able to define the word prevalence, because that is at the heart of this particular learning outcome. And as the guide shows us here, prevalence is a statistical concept in medicine or psychiatry, which is also medicine. It refers to the percentage of individuals within a population who are affected by a specific disorder, either currently or during their lifetime. Prevalence rates change cross-culturally between genders as well too. So let me give it to you in a nutshell here. So let's say the common cold, something we can all relate to. The common cold and a prevalence rate. That we can say that the prevalence rate for teenagers with a common cold, teenagers between the age of 13 and 19, is fairly high between the months of, let's say, October and the months of March. So let's say the prevalence rate as a percentage would be 60 to 70%. Let's just split the difference. 65% of teenagers across the board are prone to coming down with a cold once every year between the months of October and March, between the ages of 13 and 19 years of age. So you look at it and you say, wow, that's a pretty high prevalence rate. Whereas adults, the prevalence rate of a cold would be, well, let's say between the age of 25 and 55 would be 20%, okay? And that's at any given time of the year, 20% prevalence rate, spiking more so in the winter months. So we would say, in comparison, the prevalence rate for the common cold occurs more frequently among teenagers than it does among adults. But if we were to look at prevalence rate of the common cold among preteens to children, let's say age 5 to age 12, and let's say that's an 80% prevalence rate all year round, then we would sit there and say, well, we thought we had it bad. This age group has it even worse. So there's a higher prevalence rate, and it seems to be going down the older you get. So that's what we're looking for when we're looking at how often a particular disorder occurs within any given population at any given time. And when we say population, we're also thinking about cultures. Okay, keep that in the back of your mind. We're thinking about cultures as well too. So let's go ahead and take a look at the very first one, and that is affective disorder. And affective disorder, as the name seems to imply, it is affecting a person's outlook on life and how they have a tendency to perceive their world. And the first one is called major depression. You generally have heard people talk about it just as depression. And that's true. The two are pretty much synonymous with each other. The difference being, and let's just cover the difference before we talk about the symptoms themselves. The difference is that most everybody at one time in their life will have a depressive moment. Lose a loved one, you're going to suffer about a depression. Break up with a girlfriend or a boyfriend, you're going to have a depressive moment. Things like this, they're temporary in their nature. So there are depressive episodes that we experience throughout our life, and that we recover from those episodes as time goes on. Major depression takes a slightly different kind of a turn. You have no control over when it occurs and how it occurs and how long it'll stick around. Nothing you do mentally or physically can really bring you out of that so-called depressive episode, or that funk, if you will allow me to say that. So let's talk about the symptoms, which is the first thing we have to cover in describing symptoms, and then the prevalence will be the next one. So in major depression, the symptoms are typical symptoms of major depression. Okay, the psychological is fatigue and loss of energy. Usually there is a significant weight loss or gain. All right, there is a loss of appetite. There's usually an associated headache that goes with it, and generalized pain. Sometimes it's specific pain, sometimes it's just generalized pain. So these are I'm sorry, I said psychological, physiological, okay, dealing with the human body, physiological, not psychological. Then let's talk about the cognitive process, the thinking process. There's a feeling of worthlessness or excessive guilt. If I had done this differently, maybe she wouldn't have left me, okay? I'm completely worthless. Here's a good example. Go back to the cartoon show Winnie the Pooh. Go back to Winnie the Pooh and name the character that most seriously reminds you of major depression. And you're going to come up with Eeyore, okay? Why bother? Why bother? Okay? It's worthlessness. Difficulty concentrating, negative attitudes towards the self, the individual. Well, I don't know why I'm going to try it. It's not going to work out because I always fail. The world, what does it matter? We're all going to go to hell in a handbasket. Okay? And the future. Why vote? They all suck. Okay? And it's not going to make a difference. A feeling of guilt and worthlessness seem to be the symptoms that are primarily experienced in Western culture. Let me repeat that again. Feelings of guilt and worthlessness appear to be the symptoms that are most primary experienced in the Western cultures. That's our culture, European culture, Canadians, the Canadians too. Those are the symptoms that we most bring about, all right? Now let's talk about the emotion, okay, which is also kind of cognitive as well too. Distress and sadness, loss of interest in the world, okay? Then behavioral. This is where we note disturbed sleeping patterns, sleeping throughout the day but not sleeping at night, broken sleeping patterns that fall asleep but not stay asleep through the night, things of this nature. Self-destructive behaviors, i.e. cutting oneself, not bathing on a regular basis, not caring for themselves, suicidal thoughts, most prevalent suicidal thoughts. We call suicidal ideations when you verbalize it and when you think about it. Now, there is a difference. There is a difference. Most people at one time or another will think about suicide. Okay? Let me state this again. Most people at one time or another will think about suicide. Whether they act upon it or not, whether they verbalize it or not, okay, is a whole different story. Okay? Most people wonder, like that famous movie that had Jimmy Stewart in it, It's a Wonderful Life, in which Jimmy Stewart is faced with that, what he visualizes, that insurmountable error in the bank, and he thinks, oh my God, they're going to take everything. I'm ruined financially. Oh my God, what am I going to do? And then he wishes out loud. I can't remember if it was out loud, but he wishes that what the world would be like if he hadn't ever been born. And if you think about it, that is a suicidal thought. What if I was never here? It is a suicidal thought. And then you know the rest of the movie. And if you don't come ask me, because I'm not going to help you with it. And then the last one is avoidance of social company. I want to be alone. I don't want to be in other people's company because they're happy. I'm not happy. Why should I go? All right. So behavioral, again, is disturbed sleeping patterns, self-destructive behavior, to include suicidal thoughts, and the avoidance of social company. Now let's move on to the second part of this learning outcome, and that is the prevalence. Remember, how many times does it occur within a given population? Well, the National Comorbidity Study that was done in '94, this is right from your source, found that prevalence for lifetime major depression in the U.S. was about 17.1%. Now, this statistic is relatively new. Go take a look at the copyright, and the statistic came from the year before as a reporting. The National Institutes of Mental Health, which has online sources, by the way, in the U.S. found that the lifetime prevalence of depression was about 16.6%, with 13.2% for males and 20% for females. So this statistic, these sets of numbers that I've just given to you here, should tell you quite a bit. So if in the United States, 17.1% of the population are diagnosed through reporting sources such as psychologists, psychiatrists, social workers, other mental health care providers, and so forth, report out the case of major depression, that in the total population for the year 1994, there's the statistical year, that 17.1% of the population were diagnosed with major depression. But here's the kicker. They found that the lifetime prevalence, that means continuing on beyond just a single reported case, drops to 16.6. Not a huge drop here, okay? Not a huge drop, but a drop nevertheless. So those people that stay with the diagnosis of depression, major depression, are 16.6% of the population, according to the study from 1994. That means that one-time cases can overcome their depression and never have a recurrence of it again. But even then, 16.6%, or we can round it to 17% of the population do. Okay? Now, it's up to you to see the glass half full or half empty here, whether that's a good number or a bad number. I kind of see it as it's probably a number that's on the rise. Okay? But of that, and here's another comparison, 13.2% are men, okay, with that reoccurrence, a prevalence, lifetime prevalence, okay, 13.2%, and 20.2% for females. So on the surface, we could say that women more often than men, okay, are going to end up with major depression versus, women are going to end up with major depression versus men at a slightly higher rate. Well, this is actually a pretty good rate, a difference between the two, 8%, something like that. No, not 8%. Okay, and so when you look at it this way, you say, as a woman, okay, you stand more of a chance of coming down with depression, so to speak, if you look at it that way. So let's take a look at the studies that support what we're looking at here. Let's take a look at the first one. You can follow along with me. In this 2003 study, they found that lifetime prevalence of depression varies across cultures. For example, they gave 3% in Japan and 17% of the United States. 3% depression in Japan and 17% in the United States. Again, is it really truly that the Japanese suffer from less depression? Or do they just, remember now, the Japanese culture really emphasizes saving the face. So is it that they're sufferers, but they won't admit that they're sufferers? Got it? Let's go back to 5.3 when it comes to cultural and ethical considerations in diagnosis. This is a real good example to argue one with the other. The next study here, I think it's an Indian name, Pungangafi, I think it is, found an overall prevalence rate of depression in the city of, Chennai in South India, so I guess he is Indian, of 15.9%. The study was based on 25,000 participants. Depression was assessed through a self-reporting instrument, all right, and depressed moods were the most common symptoms, followed by fatigue. Suicidal thoughts were less common, and generally depression rates were higher in the lower income groups compared to the high income groups, and the prevalence of depression was also higher among divorced and widowed compared to the current married respondents. Here, in this particular study, you've got to know something about the Indian culture, where family is considered to be very, very important. So why wouldn't you see higher prevalence rates in those that are single without families? Okay, those in the lower class. Remember, they had a caste system that they're trying to get rid of. Whether it's successful or unsuccessful, it's entirely up to them. Then the last study is the Kessler et al. Study, 93. They found a lifetime prevalence rate for major depression of 21.3 in women compared to 12.7. And this was the year before the National Comorbidity Study of 94. So we're not dealing with numbers that are too far afield. 12.7 compared to 13.2 and 21.3 versus 20.2. We could say that Kessler study shows, in comparison to the comorbidity study, a slight drop in major lifetime prevalence of major depression. So let's go on to the next one. Let's talk about eating disorders. All right, so the eating disorder that we're going to be talking about is bulimia nervosa. Okay, there are two major eating disorders that we talk about in psychology, and bulimia is one of them. The other one being anorexia. Okay, and so with bulimia, we have a slightly different symptom. Typical symptoms of bulimia, according to the DSM, include psychophysiological, right? Nutritional deficiencies and hormonal changes could lead to disturbances in the menstrual cycle, result in fatigue, digestive problems, and muscle cramping. And let me clarify this. Bulimia is the eating disorder in which people will eat and then purge themselves soon afterwards. Eat it then either through guilt or a planned episode. They will go ahead and either stick their finger down their throat and purge themselves with it. I've also heard cases where people will go ahead and take something to help them go to the bathroom. So they'll have a bowel movement and get rid of it that way. Either way, what they're doing is they're not allowing the stomach to break down the food content in its nutritional value, taking the vitamins and the minerals from it and using it as a beneficial entity for the body, so that the person does not get the nutritional benefits of food, and this results in hormonal changes, and it leads to disturbances in the menstrual cycle, fatigue, digestive problems, and then muscle cramps. The cognitive process here is the distorted body image. Usually people that are experiencing bulimia, and to a lesser degree anorexia, have low self-esteem. Okay, a sense of a lack of control during binge eating episodes. There are some fantastic YouTube videos out there. There was one, I believe it may have been pulled from the YouTube server, but there was one teenage girl that showed you what she would binge upon, and she suffered from bulimia. And she would tell you physically put in front of you the foods that she would binge upon and then purge herself of. It was rather interesting to see. It's probably in the neighborhood of 5,800 calories in one particular setting. Half gallon of ice cream, to name a few, couple bags of chips, things of cookies and so on and so forth, candies and such like this. She just laid it out there on the bed and on the floor, and she video recorded this whole thing. The emotional context there is that there's a fear of becoming fat, a fat phobia, if you will, body dissatisfaction, and depressed mood. If we were to poll every teenager in the high school population, we would probably come up with a pretty high percentage that found something wrong with their body. There's something about your particular body that you don't particularly care for. It's your hair, it's your nose, your ears, pardon me, your size. You're too big, you're too small, you don't have enough muscle mass, you're too short, too tall. You don't like your hands, you don't like your shoulders, you don't like this, you don't like that. It's easy. It's very easy to find something at fault with our own selves as an adolescent. When you become an adult, you kind of wean yourself off of that, and eventually what happens is that you just stop caring. And you've probably seen that in me when I was in front of you many times. I would come with my hair combed or my hair uncombed, shaved, unshaven. Sometimes you just stop caring about it. One may say, you got your wife, okay? You don't need to look attractive to the opposite sex anymore because you're not having to try. Maybe there's something to it. I really don't know. But as a teenager, you're going to be more self-conscious of your own body, whether you're too fat, too skinny, whatever. Then the last one is behavioral. Self-starving in combination with recurrent binge eating episodes and compensatory behavior such as vomiting and misuse of laxatives to avoid gaining weight. This is something that, it occurs quite a bit. So let's talk about the prevalence. And for the prevalence, we have 3 studies to look at as well, too. And the first of these is going to be the Fairbairn and Belgen study, a 1990 study. He found that bulimia nervosa affected between 1 and 2% of young women in the United States and the UK. All right, it was estimated that 1 to 3% of young adult females to have bulimia. The disorder occurs much less frequently in men. And that is actually very, very true. Bulimia and anorexia are much higher in women than it is in men. And think about this for just a moment, please. You pick up, go buy a magazine rack, okay? The library, not our library, but a public library, or just someplace that sells magazines on a whole bookstore, for instance. And you will find that on there, in your fashion magazines especially, you're going to find people that look good. Okay, the bodies look good. They dress well. You find very little to no blemishes on their skin. Things of this nature. They look like the perfect body type. And so you see this more often than not. Then what do you perceive of your own self if you can't meet that expectation that is supposed to be expected of you in the so-called fictitious world of the media? And so this contributes to bulimia, and a lot of studies will tell you this. Let's go on to the Drewnowski study. Drewnowski et al., 1988, conducted a telephone survey with a representative sample of 1,000 males and female students in the United States. They found that 1% of the women and 0.2% of men were classified as bulimic. Bulimia nervosa was most prevalent among undergraduate women living on campus, and probably with a similar rate to high school girls. Okay. The Drewnowski study is not your best study to quote for any type of paper here, but the problem is that it was a telephone survey and not an in-depth analysis. But we mention it here because it can add to an argument you're trying to make. The last one here is the Kell and Klump. That's kind of funny. Kell and Klump study of 2003. They performed a meta-analysis of research on bulimia nervosa and found an increase in people diagnosed with bulimia from 1970 to 1993. There are no incident data for bulimia prior to 1970. The diagnosis criteria for bulimia have become more stringent over the years and has resulted in an increase in incidences. According to researchers, the self-reported survey, here we go, self-reported survey, tends to produce higher estimates of bulimia nervosa prevalence than structured clinical interviews. And right to the heart of this is this idea that prior to 1970, nobody knew what bulimia was. Nobody knew what anorexia was. Case in point, and you probably don't remember this, go ask your mom and dad. There was a singing group that was very popular in the 1970s, and they were the Carpenters. Karen Carpenter and her brother, well, I've drawn a blank. Anyway, Karen Carpenter suffered from anorexia. And if you go online, you'll see the pictures of her when she was at her prime. I think she was a thin girl to begin with, and but she got thinner and more gaunt as time went on. She eventually died from complications of anorexia. And when this was reported out that she had just essentially starved herself to death, a lot of people were wondering, why would you do something like this? And then thinking back to my high school days, I remember a girl telling another girl very openly, well, if you need to, you can always just go ahead and just keep eating what you're eating, but just stick your finger down your throat and throw up, that way you can keep the pounds off. So in the 1970s, we really didn't talk or have the dialogue with regard to this could cause long-range problems, long-term problems. And so we were just seeing it being reported. And a lot of this was behind closed doors and not readily open for discussion. So today, let's just go ahead and verbally cover what we've covered. We talked about describing symptoms and prevalence of two disorders. We looked at affective disorder and eating disorder in this one. We talked about what prevalence meant. It's a statistical concept which essentially asks you how often is this occurring within any given population. And with major depression, we talked about the symptoms of major depression, which is pretty easy to figure out. That's why I kind of stay with this one, or suggest that you stay with this one. I have no control over what you do anymore. Then we have the eating disorder of bulimia. And bulimia is fairly easy as well, too, because the symptomology is pretty clear-cut. So you've got the symptoms of the two, and you should be able to really just quickly review them, look at them, distinguish between what is bulimia and what is anorexia. Stay to the bulimia side, you got the symptoms down. The prevalence rate, just estimate it. You don't have to be perfect on your estimation, but this is a level 1 kind of a question. So it's not likely you're going to see this one on day 2 exam unless they change the wording on this particular learning outcome. I would suggest as an assignment between all of you is to come away with an idea of how you would respond to this if this were given to you as a level 3 question. And you could take any one of those prompts, command terms from the back of the study guide and try to work it into a long answer question and response, and then try it off of each other. And that's a good way to approach these things, is to, okay, just sit there and say, let's discuss cultural and ethical considerations and diagnoses. How would we approach that question? As a group, you can talk about it. As a group, you could talk about how you would go ahead and mention it and how you'd begin your essay, all right, and see if somebody else has a better suggestion, because what you're doing essentially is just peer reviewing with each other, and that's fine because it gives you better confidence on how you're going to go into that May exam and answer those questions. So that's all I have for you right now. Thanks for listening. The next time I record, we have a level 2. We're going to analyze etiologies in terms of biological, cognitive, and or social cultural factors of one disorder from 2 of the following groups: anxiety, actually, we're going to leave anxiety out, affective disorder, and eating disorder. So we're going to look at major depression again and bulimia. And this is the big one. So I'll try to get this one ready for you in relatively short order. All right? Bye-bye.